I know that there's been a ton of asthma throughout the last several days. Let me see if I get this. And so I thought I'd take a little bit of a different approach, which is really just to review, but also to raise a lot of questions as we think forward with the use of these agents. And so my goal today is talk about precision and personalized asthma therapy, why? And I do have a number of disclosures. I have been a consultant for AstraZeneca and worked and have a grant from Novartis and have CDC, NIOSH, and NIH grants. So the first why is what you've been hearing for the last several days, which is that we still have this problem in the United States as well as throughout the rest of the world of uncontrolled asthma. And this is a picture from CDC data doing an asthma callback survey and looking at who has uncontrolled asthma. And really about 50% of the adults in the United States had uncontrolled asthma and almost 40%. So that tells us the first why, which is we have a real problem. It's a continued problem. I like to think about severe asthma according to the WHO guidelines, which is sort of breaks severe asthma into three groups: those who have untreated asthma, those who have difficult to treat asthma, and those who have treatment-resistant asthma, with uncontrolled asthma being asthma that can result in the risk of frequent severe exacerbations or chronic morbidity, including eventually impaired lung function. Clearly, we're not talking about the untreated group today, but we are talking about those who have difficult to treat or treatment-resistant asthma. And the difficult to treat asthma are those who may have adherence issues, those who have comorbidity issues, as well as other issues that may complicate their disease, whereas the treatment-resistant are those who, despite all treatment, have continued failure to have control. And about 5 to 10% of the adult population with asthma may fit into this category. And again, clearly, if we think about the difficult to treat asthmatic, there are many, many reasons why someone might have difficult to treat asthma, and that's really not the focus of this talk. But I like to think about it all the time because those of us who manage asthma know that the disease has intrinsic issues with treatment. It's chronic, it's variable, there are huge issues with adherence, there are huge issues with the medical system, there are huge issues with comorbidities, and all of those we deal with all the time. I think what's so exciting now is that maybe we can get control over some of those as we move into new advances. I show this picture, by the way, because I think you couldn't develop a system more confusing for patients if you tried, and ours get completely confused with every inhaler. So what we do know is from an old study, the GOAL study, Gaining Optimal Control study, that despite increasing all our inhaled corticosteroids and long-acting beta agonists, even with that, 40% of the adult population could not achieve well-controlled asthma, and 70% can't achieve totally controlled asthma. So indeed, despite all of these therapies, we still have a problem. And therefore, when you think about difficult to treat asthma or treatment-resistant asthma, we really need additional therapy. And that's what's so exciting right now, which is we have some new things on the horizon. So for those of us who are old enough to have been treating asthma for decades, this is really the most exciting period we've ever been in. We have currently approved agents, omalizumab, mepolizumab, reslizumab. We have some that are not approved yet, but are coming down the pike, dupilumab, I can't pronounce that one, tezepelumab, Tezi for short. But if we're going to think about using these, we really need to understand the mechanisms so that we use them appropriately. So that's what I'd like to review today. And since it's the end of the session, I think I'll just give it to you very simply. We think about type 2 disease, non-type 2. Type 2 has IgE and we can just measure IgE and EOs. And non-type 2, we can measure, maybe we can't, but we think about it as neutrophilic or paucigranulocytic. And now we can go home. So let me go through this in a little more detail, because the point is really that asthma mechanisms are complex. So now that I showed you 4 circles, your eyes can glaze over with these cartoons that we see over and over again. And the point about these cartoons is, in fact, they really do tell us something. They tell us that there's lots of stimuli for asthma. They tell us that there are heterogeneous pathways, and they tell us that there are redundant pathways. So that, again, tells us that there's a difficulty with managing asthma, that, as we know from the old leukotriene story, hitting one target may or may not really be the be-all and end-all, but of course it may depend where that target is and what target it is. So the first issue is we have a multiplicity of exogenous stimuli. For example, allergens, viruses, pollutants, microbes. And that tells us something, that there's going to be lots of different pathways involved, since we know all of these are not acting in the same way. And the classic pathway that we think about for asthma is clearly the Th2 pathway, where we have an allergen that upregulates or stimulates an adaptive immune response that involves a Th2 cell. The Th2 cell can synthesize IL-4 and IL-13, which causes isotype switching and the generation of IgE. And this is now dogma for all of us, and we all know that. We also know that that pathway actually can stimulate multiple effector molecules or cells, not only IgE, but also through the synthesis of IL-5, can recruit and activate eosinophils. But think about the other agents, viruses, pollutants, microbes. So we know that there's a lot of patients who have asthma and don't have IgE, and the question has been for a long time, what's stimulating those patients? Where are they getting their stimuli from? And we know that there's a role for viruses, pollutants, microbes, we can call them alarmins. And what in 2010, a new cell, an innate lymphoid cell 2, type 2 cell, was identified. And that was really a huge breakthrough for us, because what that cell does is very much like a Th2 cell, although it's not a Th2 cell, it doesn't have the same markers. That cell can make IL-5 and cause the recruitment and activation of eosinophils, and it can also, depending on the circumstances, make IL-4 and IL-13. So ILC2 cells are cells that lack Th2 lymphocyte markers. They can synthesize IL-5, 4, and 13, but they also are heterogeneous, so they're not all the same. And their synthesis of select cytokines may depend on the stimulus, so they're clearly, as we learn more and more about them, more and more complicated. But the point is that viruses and pollutants and microbes can activate ILC2 cells, but not only, they can also be activated by allergens. So this tells us that, in fact, now we have multiple pathways, a Th2 pathway and an ILC2 pathway, both which are redundant, that can give us a lot of the very same end products, IgE, eosinophils, and even IL-13 functions. So that tells us something, that we have lots of repeated signals in asthma. And if we're going to start thinking about intervening, we have to understand that there may be multiple pathways that are involved. And in fact, one can be an isolated, for example, Th2 pathway or an isolated ILC2 pathway, but it turns out that they may actually interact. And in a very, very beautiful study that was just recently published by Chen from Canada, what they did was look at sputum, blood, and also bone marrow after allergen channel. And what they found, in fact, was that ILC2 cells were increased and activated very rapidly, 24 hours in the sputum. CD4 positive T cells were also recruited and activated very rapidly in the sputum, 24 hours. But they remained longer in the sputum and also in the blood, unlike ILC2 cells. So that tells us that there's redundancy, but they're not exactly the same. There's different stimuli, and they may be doing similar things, but not identical. So how are we beginning to intervene? And you're going to hear how and who to do this in, but let me take you through a little bit the pathways and some of the issues that we're seeing. So the first biologic agent that came out was certainly omalizumab, which blocks IgE, binds IgE and blocks the activity of IgE. And it was really our first endo or phenotype-directed therapy. So it was really an amazing agent to have on hand. And that blocks IgE, so usually we think about that as an allergen-induced pathway. And we knew over the years, we've used it for many, many, many years now. It has a very good safety profile. And we know that many, many individuals with elevated IgE levels, i.e. they fit the criteria for use of the drug, really do improve. But we know that not all of them improve. So that raises a very interesting question. How actually is this agent working? Who actually should it be working in? And you're going to hear a little bit more about that in the next talk. But we know that there's different characteristics of people that might start to predict who's going to improve. But it tells us that this is not a simple pathway. Even just the IgE pathway is complicated. What about IL-5, where we're learning more and more as the new biologic agents that target IL-5 as a single target? And again, if you think about this, so here we're targeting eosinophils. So now we're getting redundant pathways, but the same endpoint. So the same single target, but it's the endpoint of multiple pathways. So the IL-5 agents that are approved currently are mepolizumab, approved in 2015. Reslizumab intravenous was approved in 2016. The sub-Q agent is not yet approved. And then there's another agent which works a little bit differently, benralizumab, which actually blocks one of the an IL-5 receptor and works a little different. It's cytotoxic for the eosinophils, not yet approved, but its approval is imminent. So these agents really hit one target, an end-stage effector cell target, and we now know, again, with numerous studies, that in fact, they are very, very effective. In fact, for those of us who have used them, it's extraordinarily exciting to use them in many of our patients. But not everybody responds. So we don't know exactly why that is. We know that the higher your eosinophils, the more likely you are to respond. But we often get an incomplete response. We don't know why that is. Is it that the disease is not eosinophil mediated? Is it the antibody has a different affinity or avidity? Is it the way we're delivering it? A recent study suggests that, in fact, you might have to do it a little bit more weight-based. Is it not getting to the right compartment? Or are we using the wrong dose? Or is this just a different mechanism? So again, this is going to raise very interesting questions. This is a study by Ortega showing you the effect of mepolizumab when given intravenously in terms of cumulative number of asthma exacerbations, and you can see it has a major effect, but it doesn't take us down to zero. So in many patients, there's still something else, some other process going on, or we're delivering it incompletely to that patient. So if these pathways are heterogeneous and if they're redundant, is one target enough? Again, those of us who grew up in the asthma era when we were doing the anti-leukotrienes, we thought we had the be-all and end-all. We had this one wonderful drug. It should have worked, and it didn't, and probably, or didn't enough, probably because there are heterogeneous pathways, redundant pathways, and not all asthmatics are the same. So we have a couple of agents that are being developed now that actually hit multiple pathways, and the first one that you all know about is dupilumab. So dupilumab is a fully humanized monoclonal antibody. It's directed against the IL-4R alpha receptor, which is a component of the receptor for both IL-4 and IL-13. So it hits both IL-4 pathways as well as IL-13 pathways. So it's going to hit, again, redundant pathways that are involved with those two cytokines. It's not yet approved. We only really have phase 2 studies. This is a recent one that was published in The Lancet, and this shows you a reduction in exacerbations, and that reduction, these are different doses, but that reduction was seen in the total population, but importantly was also seen in those who had high eosinophils as well as those that had low eosinophils. So this is beginning to say maybe, we don't quite know how to classify a type 2, that this is an IL-4, IL-13 pathway, and we need to start thinking really specific pathways. But it suggests that if you hit two agents, you might be getting nice efficacy. Is this enough? Well, one of the more exciting advances we've had in the last few years in understanding asthma pathways was really in beginning to understand the role of the epithelial cell. We used to think of the epithelial cell as a barrier cell. We now understand that the epithelial cell in it of itself can synthesize a number of really, really important cytokines, IL-33, thymic stromal lymphopoietin, TSLP, and IL-25. And it can synthesize these in response to allergens, viruses, pollutants, microbes. So really these are ubiquitous stimuli for this. And in fact, these agents can actually upregulate both a Th2 pathway and an ILC2 pathway. So they're epithelial cell-derived cytokines that get redundant pathways, leading to IgE, eosinophils, etc. So we currently have, again, not approved, but only phase 2 studies, and really just the first study, first phase 2 coming out, but very interesting, using tezepelumab. It should be tezepelumab. Anyway, tezepelumab, which to block TSLP. And again, it looks very interesting, where at least they get a 60 to 70% reduction in asthma exacerbation rates. Again, doesn't depend on the peripheral eosinophils. So this is going to be very interesting. Clearly, one of the things we're going to worry about when you're looking at upstream pathways, is it going to be safe? What's the safety profile? Because you're going to have such a wide effect. But so far in the preliminary studies, it looks relatively safe. But I think this is really something that's going to be very interesting coming down the pike. Okay. So we have asthma mechanisms, effector cells and antibodies, IgE, eosinophils. But in fact, and for type 2, we have a lot of agents approved or in development. But in fact, if you look at our patients, we don't know exactly how to judge them, but if you look by sputum studies, for example, about 50% of our patients will be non-eosinophilic. So we can put those into a non-IgE. We can put those into a non-type 2 pathway. And that involves, this is very sensitive, neutrophils, or in fact, we can identify inflammatory cells. The non-type 2 immune response is really our next group of patients that we really have nothing much more to offer and we really have to think about. We know that there are sputum inflammatory cell types, such as neutrophils, where people might have a mixed neutrophil and eosinophil type. We think that there's a variety of pathways, IL-17, IL-1, 6, 8, even the interferons that are involved in these, but we haven't really figured that out. And we haven't even figured out those who actually, if you look at their sputum, completely lack an increase in neutrophils or eosinophils. They're the paucigranulocytic group. Who are they and what's stimulating them? These are a lot of questions that we still have to figure out. So in summary, asthma pathways are complex, heterogeneous, and redundant. Current agents affect single effector targets. Multiple and upstream targets are on the horizon. But there are many questions remain for really true precision medicine. Is blocking one pathway enough? Do we need to target multiple pathways or upstream targets? How are we going to target non-type 2 pathways? How are we going to identify who's going to respond? If we say someone's a type 2, are endophenotypes pure? Or is an individual endophenotype even stable? These are all questions we need to face, but really for those of us in asthma, this is an unbelievably exciting time. So I'm going to end here. Thank you very much.